Hello, good afternoon, everyone. My name is Simona Rednic. I'm a professor of rheumatology at the University of Medicine and Pharmacy of Cluj, which is in Romania. I'm working also in a reconnet center, in the only reconnet center in Romania, and I am one of the two disease coordinators of the relapsing polychondritis group, together with Professor Laurent Arnaud, which is working in University of Strasbourg. Our relapsing polychondritis group is also represented by the two EPAGs, Lisa Matthews coming from UK and Camelia Buksha representing the patients from Romania. The subjects of today is what are the pitfalls and red flags of relapsing polychondritis to be considered for the general practitioner and also for all the healthcare professional. It will be presented by Dr. Laura Damian. She's a rheumatologist and consultant in our Department of Rheumatology in the County Emergency Hospital in Cluj. And together with Camelia Buksha, which will share with us the patient perspective, she's representing the Romanian Association of Relapsing Polychondritis. Of course, speaking about relapsing polychondritis, it is a rare disease. It is characterized more by recurrent and destructive inflammatory lesions of the cartilage of the nose and all of the ear. But it's not only about ears and noses. We can have also systemic inflammation, eye involvement, blood vessels, skin, joints, kidney, and nervous system, very rare but possible. And because of this, it can be present to different specialties, to the general practitioner, and also to the ENT, ophthalmologist, dermatologist, or cardiologist. Being a very rare condition and having such a variety of symptoms, it's rare recognized, and an early diagnosis is very important. That's why our webinar aims to highlight the most important red flags, which can underline and have the physician to think to relapsing polychondritis. I also want to tell you that this webinar is recorded and will be published on the reconnet page and also on the YouTube channel of reconnet. You can put questions if you want during the webinar to use the question and answer or the chat section. We will take questions at the end. And the questions will be addressed to the speakers at the end of the presentation. So, Laura and Camelia, we are hearing you.
Thank you for the introduction, Simona, and thank you, reconnet, for inviting us, and to you, everyone who's here at the webinar. We are presenting together with Amelia the red flags and pitfalls in relapsing polychondritis. So I'll start by saying that relapsing polychondritis is a rare multisystemic disease of unknown cause, characterized by episodic inflammation of cartilage and other proteoglycan-containing structures throughout the body, which may occur in any age, even in children, although in the mature age, it's more important, it's more prevalent. The diagnostic criteria, there are 3 sets of diagnostic criteria.
Laura, we are not seeing the slides.
Oh, sorry. Sorry, I didn't realize you're not seeing. Sorry. So I'll share the screen.
Do you have any problem?
We have a little bit. So do you see it? Sorry.
Yes.
Thank you. Sorry.
No,
Sorry
that's okay. Great. Thank you.
Thank you. So I'll pass.
Yeah.
Sorry. Have you heard it? May I? The introduction. Relapsing polychondritis may occur in any age, and there are 3 sets of criteria. The classical criteria are the McAdam criteria. For the diagnosis, is 3 or more of the following are required: bilateral auricular chondritis, inflammatory polyarthritis, which is usually non-erosive, seronegative, nasal chondritis, ocular inflammation, respiratory tract chondritis, or cochleovestibular involvement. The modified Damiani criteria require at least 3 McAdams criteria, or 1 or more McAdam criteria plus histological confirmation, or chondritis at least 2 sites, 2 separate anatomic locations responding to glucocorticoids or Depson. And the Michel criteria are the clinical ones and require either auricular, nasal, or laryngeal inflammation, or 2 of these types of involvement, or 1 auricular, nasal, or laryngeal inflammation plus one of the following, including ocular, hearing loss, and vestibular dysfunction. Why do we need less red flags? As Simona said before, because there are no specific easily employed diagnostic markers, and the polymorphic presentation and the episodic course of the disease may result in a significant diagnosis delay. Moreover, in the patients who also have fibromyalgia and do not have a very obvious chondritis of the ear, nose, or of the joints, the diagnosis may be delayed with more than 1 year. And there is a significant diagnosis burden which may be prevented by an early diagnosis and therapy. The associated disorders may occur in up to 1/3 of the relapsing polychondritis patients, mostly systemic vasculitis or systemic lupus erythematosus, rheumatoid arthritis, immunodeficiency, malignancy, and so on. Importantly, relapsing polychondritis may be part of the clinical picture of the newly described VEXA syndrome, which is the acronym of vacuoles, E1 enzyme, X-linked, autoinflammatory, and somatic. Genetic disease with adult onset evolving with fever, cytopenia, vacuoles in the myeloid and erythroid precursors, myelodysplasia, or other hematological disorders, chondritis, vasculitis, skin rashes, and a more serious systemic involvement. Another notable overlap is the so-called magic syndrome, coming from mouth and genital ulcers with inflamed cartilage, which is an overlap of relapsing polychondritis with Behçet disease, an entity which is not fully recognized by everyone as a separate entity. I'll just pass through the main types of involvement in relapsing polychondritis. The systemic involvement associates sometimes intermittent fever, weight loss, malaise, asthenia, that may be episodic, like in autoinflammatory disorders, or may be continuous. And the red flag is that severe constitutional signs may reflect the underlying disease, or maybe a sign of myelodysplastic syndrome or VEXAS syndrome. The oto-laryngological involvement is sometimes related by, is sometimes described by the patient as pain, mainly when lying on the pillow, ear pain. Also sudden hearing loss, or most often neurosensorial, may be encountered, and the whole spectrum of features related to this type of involvement, like tinnitus, vertigo, many-like symptoms, floppy ear, otitis media, ear fullness, and so on. There are several types of cartilage involvement, but in most cases, the earlobe is spared. And after several episodes, the cartilage softens and collapses forward, like in this patient, becoming floppy. And thus it's very important that as the inflammation may recede, it's helpful to ask the patients to take photos during the flares to document the episodes. There is this blue ear sign, just to be remembered, that the bluish hue of the cartilage, like in the sclera, results from the auricular or from the ocular inflammation in the case of the sclera, resulting in the thinning of the structures and giving this hue, which otherwise would have been attributed to other diseases like ochronosis and so on. Not every auricular chondritis is due to relapsing polychondritis. There is this chondrodermatitis nodularis hellicis, or the Winkler's disease, a benign auricular lesion, which is sometimes accompanied by inflammation, but this is due probably to impairment of the vascular supply. We may see it in diseases like systemic sclerosis, for instance, but it doesn't mean relapsing polychondritis. Also, something notable is that the auricular calcifications or ossification, which may deform the ear, the external ear, may be due to endocrinopathies like adrenal insufficiency or hypothyroidism or acromegaly. And sometimes they may have an equivalent, even radiological. So this also has to be there in mind. And also also frostbite may result in similar aspects, of course, to be differentiated. And the red ear syndrome, which is a form of migraine, actually, it is considered like that. It evolves with intermittent episodes of sudden redness and local inflammation of the ear, which are subsiding without any treatment and without leaving something else behind. Also, in this setting, the perichondritis, the infection of the tissue surrounding the ear cartilage, has to be taken in mind. Actually, this is the first diagnosis which the patients come to our attention, because the infection is the first diagnosis presumed, and it's correct like this for the first episode. And also for the other episodes, we have to look for an entrance gate for the pathogens to rule out an infection. And if the infections are most often due to Pseudomonas aeruginosa and are more common in immunodepressed patients, but may also be induced sometimes by piercing. Angioedema may also evolve with that. Lymphocytoma due to Borrelia, which may also involve, actually, this is the preferential site of the ear involvement in lymphocytoma, the earlobe, but also lymphoma cutis or histiocytosis like Rosai-Dorfman have been reported to mimic relapsing polychondritis. Other signs involve the medial or internal ear, and the nose, of course. The classical sign we all know is the saddle nose, which may also be to do granulomatosis with polyangiitis, maybe due to cocaine use, to infections, but also to nasal NK or T-cell lymphoma, or to trauma. But it's to be mentioned that cartilage trauma may trigger relapsing polychondritis. So a patient with this type of disorder complaining of progressive symptoms may also be checked for relapsing polychondritis. The laryngeal involvement may result in hoarse voice, in dysphonia, and also in cartilage calcifications, which may have this peculiar aspect. The respiratory involvement is very challenging to be detected, mostly in isolated respiratory presentations. And many patients present with so-called difficult asthma. This is a red flag to be remembered. And difficult asthma without response to the conventional therapy may also hide the relapsing polychondritis. Other signs like dyspnea, cough, chest pain, and others are may occur and are very unspecific. But the tracheobronchial malacia with excessive airway narrowing in expiration and widening in inspiration may lead to this diagnosis. Clinically, something not to be missed is that many patients with respiratory involvement may have anterior tracheal tenderness, which should be sought for. Some red flags: the patients undergoing only chest CT may not have the diagnosis, because the dynamic imaging should be performed in this respect. Bronchoscopy may be risky in relapsing polychondritis and therefore should be performed only when really necessary and only by experimented investigators. Also, that tracheal maneuvers may induce inflammation, which has to be bear in mind when the anesthetic management before an operation should be considered before any surgery. The ocular involvement involves with all types of eye inflammation, from conjunctivitis to episcleritis or scleritis, which are the most often present manifestations. But something to remember is that necrotizing scleritis or peripheral ulcerative keratitis are complications that may be sight-threatening due to eye perforation. And all patients presenting with this type of involvement should specifically be questioned for relapsing polychondritis symptoms. Another pitfall, that posterior scleritis in relapsing polychondritis may not evolve with red eye, anterior redness. Therefore, the patients have to be referred to ophthalmologist even if they don't have the red eye in this respect. The articular involvement consists in intermittent arthritis, migratory, usually non-erosive, sometimes palindromic, affecting large and small joints, and sometimes the relapsing polychondritis or associated arthritis bouts, which are usually asymmetrical, may occur over the associated diseases arthritis. This is the case of one of our cases, a patient with lupus who had this bout of arthritis, very inflammatory, associated with the ear chondritis, which pointed to this disease, including in the joints. The anterior chest wall involvement, the rib pain, and rarely the vertebral pain may also be signs of RP. Of course, the anterior chest pain may have multiple causes. One of the inflammatory causes is due to SAPHO syndrome or the anterior chest wall syndrome. Sometimes this is related to psoriatic arthritis or other type of spondyloarthritis. But it also good to remember that some patients are misdiagnosed for years as having Tietze syndrome. Some are RP patients with predominantly articular involvement, mainly in the chest. The cardiovascular involvement also may interest many structures. The large vessel involvement is classical, also coronary vasculitis or other type of vasculitis. The RP may lead to aortic rupture and to acute valvular insufficiency. And in this case, it's important that any patient with chest pain or discomfort should be consulted with auscultation, which may reveal changes of murmurs. And also an important thing to remember is that the aortitis and Raynaud's phenomenon are more prevalent in MAGIC syndrome, so in that overlap with Behçet syndrome, than in classical RP. The dermatological involvement also is very frequent. All types of rashes may be encountered, from vasculitis, associated rashes, to aphthosis, nodules, livedo reticularis, other types of ulcerations. But neutrophilic dermatosis, including Sweet syndrome or this type of pyoderma gangrenosum, like in this finger, they may warrant hematological examination for the presence of myelodysplastic syndrome and its associations. Neurological involvement may consist more often in sensory motor neuropathy. It's rare anyway, but the most, it's about 3% of the patients may have neurological involvement. But when they are present, cranial neuropathies involve the optic nerve and the other 6, 7, and 8 nerves. And this may be inaugural. We also had a patient with this type of symptomatology at the onset of RP. Also, an encephalitis, posterior reversible encephalopathy, meningitis, inflammatory pseudotumor, limbic encephalitis, and so on have been described. With regard to the laboratory in relapsing polychondritis, there are no specific tests, and the analyses are necessary only to rule out other diseases and infections, of course. But a flag to be remembered that when relapsing polychondritis coexists with lupus, this could be a cause. This is a cause of CRP elevation. As it is known, the C-reactive protein does not increase in lupus apart from infections and some other rare settings such as severe arthritis, vasculitis, and sometimes complication of antiphospholipid syndrome. Something about incidental RP diagnosis on imaging. In several settings, a chest X-ray may reveal tracheal narrowing or tracheal wall enlargement or calcifications of costal cartilages occurring in younger person than expected, because with age they may calcify, but not in youngsters. They are not encountered in this setting. Or the lateral cervical radiography may reveal calcifications of the laryngeal and tracheal cartilage. Also, the CT scan of the large airways performed for other reasons may reveal signs of RP with respiratory involvement, such as airway thickening, luminal narrowing, or calcifications of the cartilage. And an important examinations performed sometimes in cases of fever of unknown origin or in patients with neoplasias or myelodysplastic syndrome may reveal respiratory chondritis also in asymptomatic patients from this point of view. And this is a method useful probably with the future in assessing the activity and the presence of involvement in the RP. To conclude, recurrent chondritis, intermittent non-erosive arthritis, recurrent red eye episodes, necrotizing scleritis, saddle nose, difficult asthma, imaging findings are all red flags for relapsing polychondritis. History taking is crucial. Clinical examination may detect subtle signs. There are instruments to quantify the disease activity and damage, like the disease RP disease activity index and the disease activity damage. The relapsing polychondritis disease damage. Its teamwork is necessary with all the doctors and health professionals involved in taking care of the patient with relapsing polychondritis. And very important, the patients are partners in managing the disease and also in our understanding of the disease. Thank you for your attention. I'm giving the floor to Camelia.
Thank you, Dr. Damian, and thank you, Reconet, for allowing me to present a patient's perspective on some of the RP symptoms. As we already heard from Dr. Damian, RP diagnosis is most often a journey in time and also in a lot of visits to different specialists. So for final diagnosis may take time. During this journey, it would be useful to ask your patient to document their symptoms in a journal, and also to take photos whenever any new symptoms appear or can be related to RP. Sometimes the RP symptoms perceived by the patients as disturbing may be different from the symptoms that physicians observe. And these can also impact the quality of life. Of course, the objective symptoms are very easily to be recognized, but sometimes the subjective symptoms described by the patient, like low levels of energy or brain fog or even costochondritis, can be difficult to explain, to be explained by the patient. Even excessive tiredness with simple exercise can be difficult to be recognized as respiratory symptoms. These symptoms may also appear early in the course of the disease and may contribute to diagnosis. So please just listen to patients' descriptions of the symptoms, even if sometimes we are not medically sound. Another aspect that could be of use to the RP patient are the patient organizations, where ideally patients could find information, psychological support, maybe physical therapy. Also depends on the budget and the expenses. The collaboration between this patient organization and the specialists is also useful and can be of great use to the patient. Also, another aspect that I included on this slide is the possibility to contact the specialists in case of emergencies. Where this could be beneficial for both patients, but also for colleagues treating patients with relapsing polychondritis. To conclude, I included 2 links of relapsing polychondritis disease website on the ERN webpage. Which is under construction, but is already very full of information. And the link for the Relapsing Polychondritis Awareness and Support Patient Organization from all over Europe and lately from other countries too. Thank you.
Thank you so much. Thank you, Laura, and thank you, Camelia, for sharing with us the both perspectives, so the physician's perspective and also the patient perspective. It's clear that the diagnosis of polychondritis is a journey. It's not very easy. You said, Camelia, that it's easy to recognize. I have said that it's not so easy to recognize for the doctors which are not usually seeing it, and because it's very rare, maybe the majority of them are not seeing it regularly. I think it's very important that you pointed about those red flags. Very important are the first manifestation. Generally, the most common sign, it's ear chondritis in the beginning, and through the disease, almost all the patients, more than 90% of them, are developing ear chondritis. Also, ophthalmologic involvement, it's very frequent and common in the beginning, so maybe ophthalmologists have to be maybe a little bit learn about this disease, and of course many other symptoms. Another very difficult thing is that all the symptomatology can be intermittent and relapsing. It's coming and going, and you can lost it in the moment in which you are in front of your physician. And of course, taking photos or notes about this or something like a journal of symptoms can be very important. So if there are questions, I can't see in this moment question, also not in the chat, and also not in the question and answer section. And if they are not, I want to thank you. There are? No. No questions. So for everyone was very clear. I want to thank you to all of you for joining this very interesting webinar. I want also to thanks to our speakers, to Dr. Laura Damian and Camelia Buksha. I want to say that the webinars will be uploaded in the YouTube channel of Reconnet, and also you will be able to see it on the Reconnet webpage. Please join also the futures webinars on Reconnet webpage, also on other rare and interesting diseases. And I want to thank you, all of you again, and wishing you a nice summer. Thank you.